3-year-old female. Refractory seizures since 6 months of age. Spasms of the trunk and upper limbs. Head drops and autism. Neuroexamination at the admission showed severe developmental delay and at least 5 to 6 seizures per day. EEG showed generalized spikes. Here we have the preoperative MRI. We can see that there is an area of the right frontal lobe where the differentiation between the white matter and the gray matter is poor. You can see the opposite side where the white matter is in black and the gray matter is in gray. It's very clear over here. So this image is very suggestive of the type 2 cortical dysplasia. So if I want to remove it, so what are the surgical limits of my resection? Inferiorly, sylvian fissure. Inferiormedially, upper surface of the insula. Superiorly is this sulcus. This is approximately 2.5 to 3 centimeters above, away from the sylvian fissure. So, and how about the medial limit of my resection? So, the medial limit is the white matter. So, where to stop? If I go too deep, I can reach and open the ventricle. I don't want to do that. So, one good landmark could be the end of upper surface of the insula. That is the superior limiting sulcus of the insula. If you go deep, 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 and then you see that insula is over, you have to stop. Otherwise, you might enter the frontal horn. So what are the anterior and the posterior limits of the resection? The anterior limit will be this sulcus. I would say this is the anterior horizontal ramus of the sylvian fissure. And the posterior limit is the ascending ramus of the sylvian fissure. So actually, this cortical dysplasia occupies the pars triangularis of the inferior frontal gyrus. And here we have the axial cut of the preoperative MRI. So this girl underwent right pteriana approach for this cortical dysplasia. So here is the exposure after the dural opening. This is the sylvian fissure. This is the right temporal lobe. This is the right frontal lobe. This is the cortical dysplasia. And here will be the anterior limit, superior limit, and the posterior limit of the cortical dysplasia. So we start the surgery with opening of the sylvian fissure because I want to see the inferior limit first. I want to see the sylvian fissure. I want to see the insula. And then I'll go and remove the cortical dysplasia. So we established first some of the main limits of our cortical resection. In children, in general, the arachnoid membrane is thicker than in adults. So gentle movement, not to damage any vein. So a very good microsurgical training, and was dissecting. This is I'm trying to expose a little bit of the horizontal ramus of the sylvian fissure, the anterior limit of our resection. Here is the insula. And I'm placing a cottonoid to occupy the already opened space. So we'll keep it open. I want to remove this part of the cortical dysplasia, but I don't want to sacrifice this cortical branch of the MCA because it will supply, the areas over here of the brain. So I have to work on each side of the cortical branch of the MCA. Now I'm establishing where I want to debulk because I want to get a lot of samples for analysis, histology analysis. Type 2 cortical dysplasia is very hard, usually very hard, so you have to use stronger scissors to cut this cortical dysplasia. Cortical dysplasia is essentially gray matter. You can see the gray matter here. In general, it's very hard. This is we call a sub-peel technique. I'm peeling the brain off the sulcus over here. Why this kind of technique? Because by peeling the brain off the arachnoid, you are keeping the veins and the small arteries inside the sulcus intact. You don't open the sulcus. So this is a very safe technique. And I just kept debulking the cortical dysplasia, so we can get a lot of samples for the histology analysis. So I'm still keeping that cortical branch intact over here. And now applying again the sub-peel dissection technique. I'm peeling gently the brain off the arachnoid membrane. The same technique can be repeated here over the posterior limit of the cortical dysplasia, keeping the sulcus intact. I will not enter the sulcus, so keeping all the veins and arteries inside the sulcus intact. I'm doing the same technique here over the surface of the insula. So I'm preserving the M2 branches and also M3 branches of the MCA. And here we are at the upper limits of the resection. We have reached the white matter. And how deep can I go? And not to get into the frontal horn. We have analyzed preoperative MRI that the best landmark to resect the white matter and also avoiding the frontal horn is to see where the location of the superior limiting sulcus of the insula. So I can see the insula over here was there. We can see later. And we are already in the middle of the white matter. So I have to check where the superior limiting sulcus of insula is located. So that's where I have to stop, avoiding going deeper into the white matter. Removing the whole cortical dysplasia. You can see this is superior limiting sulcus of insula, and then that is a place where I should stop. So this is a total resection, the final aspect, maintaining intact the cortical branch of MCA, and here we have the insula and we have the superior limiting sulcus of the insula. And here we have the postoperative MRI showing the total removal of the cortical dysplasia. You can see how close we were, very close to the frontal horn over here. Here we have a T1. You can see the distance. Here we have the postoperative MRI, coronal cut showing the total removal of the cortical dysplasia. And once again, you can look how close we were in relation to the frontal horn. More postoperative coronal MRI and the sagittal cut of the postoperative MRI. And she became seizure-free after the surgery done in 2019, and she's making significant progress in her neuropsychomotor development. and still on therapy for autism.